be autoimmune encephalitis. So, and also including autoimmune NMDA encephalitis. He has led a lot of clinical and experimental discovery in that field here and in Spain, and of course around the world. Recently, he has chaired the autoimmune neurology at AAN and is editor-in-chief of that section in neurology. When he's not increasing our knowledge through his own research, he is mentoring several talented young professionals, given lectures around the world, and has been the recipient of a slew of awards and grants, including at least 3 current grants. So with that, I do open the stage to Dr. Dalmau for our talk for today.
Well, thank you very much for inviting me. I hope you can hear me. Can you hear me? Yes, excellent. So let me share the screen. Can you see now the first slide, right? Okay. So, well, thank you for inviting me to give this grand round. It's going to be a general overview of what has been happening over the last 15 years, basically, in this field, which is a new field that has had a very fast-growing evolution, right? So I'm going to give you an update on the autoimmune encephalitis and how these disorders were identified, and then I'm going to talk mainly thinking that most of you are pediatricians. I'm not going to talk about the MOGAD, but which in pediatrics is essentially you have to remember basically 2 diseases, MOGAD and NMDA receptor encephalitis. Basically, most of the other paraneoplastic encephalitis that are in panels in Mayo Clinic, etc. You basically you will not see in the field of pediatrics many of these diseases. So, if we had to, or if I had to summarize the landscape of how things were approximately 20 years ago in the field of autoimmune neurology, let's say it, or antibodies-associated central nervous system diseases, you would find 2 groups of diseases. If this was like done, these grand rounds like 20 years ago, you would find you will find the group of paraneoplastic syndromes, right, which are also many of them autoimmune type of encephalitis, but by paraneoplastic mechanisms. And this is in this side of the slide. And in here, there are many diseases, many paraneoplastic syndromes with antibodies. The antibodies target intracellular proteins. But the main pathogenic mechanism of these diseases is basically mediated by T cells. So the antibodies can be used as markers for the clinician to, if they suspect that the patient has a paraneoplastic syndrome, but the antibodies are not really pathogenic. In the field of pediatrics, basically paraneoplastic neurological syndromes associated with these antibodies basically are almost inexistent. You have opsoclonus, myoclonus, paraneoplastic in children, but they don't associate with any specific antibodies. Or if there are some patients with antibodies, they are anecdotal and you don't know what to make of it, or probably related to the neuroblastoma, but nothing much. And then there was this other group of diseases, basically only 2, of the neuromuscular junction, mediated by antibodies. One would be myasthenia gravis, in that the targets are the acetylcholine receptors here in the postsynaptic cleft. So the antibodies bind here and in some way cause damage to the postsynaptic region in the muscle and the receptors, the acetylcholine. And the other disorder is the Lambert-Eaton myasthenic syndrome, in that the patients had antibodies against the voltage-gated calcium channels and they block the function of the channels. They reduce the amount of quanta of acetylcholine that are released, and they cause the myasthenic syndrome, right? The Lambert-Eaton. The Lambert-Eaton is also 100%, basically 50% of the patients have a cancer, usually lung cancer. But this was basically the field about 20 years ago. And the other thing that was important to keep in mind is that the group of diseases that I mentioned before are mediated by T cells, as I indicated. You can see here in the biopsy and autopsy of patients, right? This is in the temporal lobe of a patient with limbic encephalitis. You have neurons that are indented by T cells, right? And in here you have a patient with cerebellar degeneration. This should be a Purkinje cell, but you don't see it because it's being phagocytated by all these T cells that are destroying the Purkinje cells. So these are basically irreversible. Or if you treat them very early, you can improve partially the symptoms of the patient, but they are much less reversible than the ones in that the antibodies are directly causing the pathogenesis and the alterations, like the myasthenia gravis or the Lambert-Eaton myasthenic syndrome. In these, you use immune therapy and the patients can recover completely, which basically never happens in these ones. So this was their scenario. And I remember that many people ask if, how is that these type of reversible diseases mediated by antibodies against cell surface proteins or receptors, how is only occurring in the neuromuscular junction, but not in the brain? And if there are central nervous system disorders also mediated by antibodies. And at that time, there were basically none. But this led us to some studies, and one of the critical studies was reported in 2005. That was based in the study of 4 patients. All 4 were young, relatively young women, and the youngest of 14 years old, and all 4 had a remarkable similarity of symptoms. All have presented with psychiatric symptoms, and that were rapidly followed or simultaneous with another type of group of symptoms, more neurological, like insomnia, abnormal movement, seizures, autonomic instability, central hypoventilation, in the context of inflammation, of CSF inflammatory changes. And all 4 had an ovarian teratoma. And this paper was published with only 4 patients, but it was not a trivial observation, because until that point, patients that presented with CNS seemingly autoimmune encephalitis were from the category of the classical paraneoplastic syndromes and didn't do very well. These patients actually did remarkably well, 3 of them, and 1 of them died during the process of recovery. She was in a nursing care home and died a complication. And this was reported with this triad of symptoms, right? Paraneoplastic encephalitis, psychiatric symptoms, and hypoventilation, along with ovarian teratoma. We identified antibodies in these 4 patients, and these antibodies showed a remarkable immunostaining of the brain. You can see here, actually, sometimes you don't need microscope for these antibodies. Of course, you need the microscope to characterize well the pattern, but you show here a slide, simply a slide, with a section of brain of a rat, sagittal, this would be the frontal, this would be cerebellar, and reacted with or incubated with the spinal fluid of one of these patients, but all 4 showed the same reactivity. And this is a control. So this means a section of rat brain incubated with CSF of a control individual. And what you see here actually is in live neurons. So these are cultures of live neurons. The nucleus is indicated with this type of marker here, it's called API. And everything that you see in green is the reactivity of the antibodies of one of these patients. So all 4 were identical with the cell surface proteins, which at that time, we didn't know what the proteins were. And this came basically in a very rapid course of events This was the paper that I just showed you. And this basically in 1 year and a half, we identified and then published that the target antigens were the NMDA receptors. And in here there were these 4 patients and 8 more, total of 12 patients. But as soon as this was published, and there was a very rapid increase of the number of patients identified, not because of the antibody testing, but because of the recognition of the syndrome along with the antibody testing. But this was not type of shooting in the dark that I have a patient, I don't know what the patient has, so let's try if it has an antibody. This was more based on, okay, I have a patient that has the same similar symptoms as the patient reported here. And it happens that these patients had antibodies. Let's see, based on the symptoms, let's see if these patients had the antibodies. And it turned out that this is the way that the antibodies were looked at that time and currently. This is with brain tissue of rat. This is a coronal section, different from the previous one that I show you, sagittal section. This is in cultures of neurons, and this is in cells. This is like the cell-based assay in cells that express the receptors incubated with a CSF of one of the patients. This is a commercial antibody against the NMDA receptors, and the patient's antibodies and the commercial react similarly. As you can see here, green plus red is the overlay in yellow. This is a perfect colocalization. So this was the beginning of a very interesting field of research, right, that very soon led to 577 patients in this paper characterizing the NMDA receptor encephalitis demographics. What you see here is that the patients with this disease are most of them younger than 50, that basically close to 40%, 36% are in the pediatric age. And what you see here in columns, different colors, is the in pink women or girls without tumor. In red are women or girls, very few girls with a tumor, and almost always a teratoma. And in blue, the boys or men without tumor, light blue or dark blue with a tumor. And what you can see, there is a predominance of women with or without tumor. This made approximately 70% of the patients. And what you see here is about 40% of the patients, actually 36%, are in the pediatric age. And the younger the patients, the less likely that the patients have a tumor. So this is the display in some way in a graphic of the disease summarizing a complex disease. In pediatrics, the NMDA receptor encephalitis patients have similar symptoms, but is not so well stereotyped like happens with other autoimmune syndromes in children. It's not so well stereotyped as in the adults. But what is common to all of them is that most of them have what's would say look like a viral-like prodrome, although many patients are, all the tests are negative, like mild headache or fever, GI problems, upper respiratory tract problems, and then it presents alterations of behavior. In adults, psychiatric symptoms are very prominent. In children also, but it's more irritability, change of behavior, and particularly insomnia. The children cannot sleep basically and in the adults also for a number of days. And in here, children sometimes they can present like this, or they present out of the blue with seizures, or even with abnormal movements. In the adults, usually after this presentation, there is a decline in the level of function, of level of consciousness. Many of them need to be in the ICU with abnormal movements, autonomic dysfunction, hypoventilation, seizures that persist, and this is in the deepest point of the deterioration, and then they start to improve slowly over months, sometimes even a couple of years. And in here, all these symptoms, all these neurological symptoms basically are resolved, but they continue with executive dysfunction, attention and deficit, some behavioral alterations. This is valid for children, but again, children can present with, for example, abnormal movements and with seizures, and is not so well delimited as here. So the MRI is not really very helpful in this disease in terms of direct proof of the disease. It's helpful to rule out other things, for example, but not to provide a specific orientation to the disease. In this study of 577 patients, 35% had non-specific findings, but the other 65% had basically a normal clinical MRI. Non-specific findings, something like this, like a flare change, sometimes with mild contrast enhancement, but very transient, and it can occur everywhere in cortex and subcortical regions, or in the cerebellum, on the brainstem. So it's not really very, and again, very specific, and again, many of them is normal. The EEG is almost always abnormal, and there is a pattern that is more seen in adults. You can see it also in children, but more in adults. That's called extreme delta bridge, that has this pattern of, is shown here. And the general EEG usually show this pattern of a slow activity, delta theta activity. The extreme delta bridge is shown like this delta activity with this bridge of fast activity on top of the wave. And many of them have pleocytosis, of course, and the initial stage of the disease. So it's a disease that you have to suspect the disease clinically, mainly because there is no specific clinical test that suggests the disease, except if you keep in mind the whole entire picture, then things start making sense. Perhaps of all of these, the most specific, but is only in a few, a small percentage of patients, is the extreme delta rash. So, and these patients, as you know, they get better. In this series of 577 patients, we were able to follow a substantial number of patients over 2 years. And this is the MRS score, modified ranking scale, which is probably not very appropriate for this disease, but this is what we had at that time. Now there are more recent studies showing that these patients also improve with more cognitive, sophisticated cognitive evaluations. But what was impressive, despite that patients being very sick at the beginning, is that after, for example, 2 years, basically 80% of the patients had an MRS score of 0. That means no functional neurological alterations, or from 0 to 2, which are really mild symptoms. So this is quite remarkable in a disease in that the patients are so sick. And in this paper, and this was accomplished by the treatment approach that is still followed in many places, that is the scaling type of treatment, right? So patients are initially treated with first-line treatment, steroids, IVIG, or plasma change, and usually steroids and IVIG. And if the patients don't improve in a few days, a couple of weeks, to move to rituximab or a combination of rituximab and cyclophosphamide. Of course, in pediatrics, rituximab is most commonly used. Cyclophosphamide is less frequently used, but this is a drug that is also quite useful, sometimes combined with rituximab, and is quite well tolerated because they don't need too much cyclophosphamide. In a couple of cycles, most of the patients substantially improved. And using this approach, you can see only with first-line therapy, this was the number of relapses, that there were more relapses that including the second-line treatment. And at that time, there were even patients, a few patients that were not treated, and some of them, as many autoimmune diseases, improve spontaneously, and some others not, but this was impossible to do this nowadays. So this is an example of one of these patients. This is a young woman, as usual, that presented with prodromal headache, neuropsychiatric symptoms, orofacial dyskinesias that you are not going to see in this video. I hope that you can see the video functioning. Seizures, hyperthermia. And you see here the patient at the end of this graph that I show you when the patient is in the ICU, ventilated, intubated, not following commands, not recognizing anything, not communicating, and with this dissociative reaction sometimes that seems that to resist the eye opening, this is like a dissociative type of activity, but the patient is not aware of this. This is the same patient recovering. She has been in the hospital a substantial number of weeks, and now she has lost a lot of weight, and it has this walk, hesitant walk, like robotic almost, is able to talk, to communicate, but doesn't form memories. And this is the patient, the same patient, a few months, not too much longer than that, and fully recovered, right? So the discovery of this disease had a number of implications for neurology, pediatrics, of course, neuroscience, neuropediatrics, I mean neuroscience, psychiatry. But let's take the angle of neurology. Well, first of all, the discovery of this patient was followed by the discovery of many other disorders associated with antibodies reacting against cell surface proteins, some of them very well known, like the glycine receptor or the AMPA receptor, or many of the receptors, the GABA B or the GABA A receptor, other with proteins that are not so well known. And one is quite fascinating, and even it's a disease of adults. I'll show it to you at the end of the talk. And so the impact of this study has been since then like the tip of the arrow in many investigations, models, and newer strategies about how to study these diseases. Is usually the NMDA receptor encephalitis. Before that, there was basically an antibody described against cell surface proteins reacting against mGluR1, described in 2 patients, and these patients developed cerebellar symptoms. But the patients with mGluR2 also develop cerebellar symptoms, etc. These are very rare. And there were the voltage-gated potassium channel antibodies. Forget about that. This is a term that it was erroneous. There are no antibodies against voltage-gated potassium channels, and the test, you should not check for these antibodies because it leads to many errors. This test is done by immunoprecipitation, and the antibodies bind to a conglomerate of proteins among which there are potassium channels, but is not very well specific. Is not very specific, and many times the proteins are intracellular, and you can find it in the context of patients that they don't have autoimmune encephalitis. So you should not test for these antibodies. And if somebody comes to you with these antibodies, you have to check if the antigen, the specific antigen, is LGI1 or is Casper2. Being pediatricians, you're not going to have this problem in looking for LGI1 or Casper2 because this in children is extremely rare, very, very rare. But you may encounter, I have a child that has been diagnosed with voltage-gated potassium channel antibodies, encephalitis. Okay, you have to take this with extreme caution, not treat the patient like it was autoimmune, and reassess the diagnosis because it should be erased from the diagnostic test. So there are limbic encephalitis. This is different also in children. Limbic encephalitis are very rare, and what I showing here is how the limbic encephalitis manifests. Usually with this involvement of the limbic system, medial temporal lobes, and there are several autoimmune encephalitis associated with antibodies against LGI1 or AMPA or GABA B. but look at these, they associate very frequently with tumors, and you don't see this in children. And the anti-LGA1 also, you basically almost very rarely you see these diseases. The two main diseases in adults, and one of them in children, is the NMDA and diseases with antibodies against neuronal proteins. I'm not talking about aquaporin 4 or the MOGAT, for example. So the two main encephalitis with antibodies against neuronal proteins is the NMDA receptor and the LGI1 encephalitis. In the LGI1 encephalitis, patients usually present with facial-brachial dystonic seizures, confusion, memory problems. The main problem here is that the patients are unable to form new memories. So they don't remember what you told the patient like 5 minutes ago. They are unable to form these new memories. They are able to remember the past 20 years ago, but not for memories. They usually associate with hyponatremia, with MRI that I showed to you. Most of the patients don't have tumor. And the CSF can be very blunt. You treat the patients with immune therapy, usually steroids or IVIG, then there is an improvement of symptoms that usually the patients substantially get better. But many of them, they still have some residual symptoms that are difficult to treat, or they remain persistent. Remember that this is a disease that occurs, the median age is about 65 years, LGI1 encephalitis. So it's very different from NMDA receptor encephalitis, but is this the main limbic encephalitis antibody mediated in adults? In children, there are a few cases reported with anti-LGI1 antibodies. They don't present the facial-brachial dystonic seizures in children, and they present memory problems, but again, it's extremely rare. So this is what the facial-brachial dystonic seizure is in an adult. Is this seizure that you just, now is going to be in the other side. You see, this is the facial and the brachial dystonic seizures. It can occur also asleep, you know. So interestingly, nobody knows why, the very few patients with LGI1 antibodies that are children, they don't develop facial brachial dystonic seizures. One disease, third disease that in pediatrics you may be interested to remember, because these can occur in children actually, is the anti-GABA receptor encephalitis. So what is the syndrome? Well, there is basically not a specific syndrome here. The patients become encephalopathic and have very prominent seizures, and many times status epilepticus. So a patient that out of the blue present with an encephalopathy type of picture, status epilepticus, inflammatory CSF, and you have an MRI that looks like this, that you can say, well, this could be like an ADEM, right? But usually see cortical, subcortical lesions that sometimes appear and disappear. There is no other autoimmune encephalitis of all the ones that I'm talking to you today that has this MRI, no one. And this MRI is very prominent, and most of the patients have, even more than 75% have this MRI. It's a severe disease, but you can treat the patients with immune therapy and anti-epileptic, anti-seizure medication, and they usually get better. And they don't associate, many times they don't associate with tumors, but some patients have thymoma and children without tumors. But be careful, because this is, after an NMDA receptor encephalitis, this is much, much less common, but it can occur in children. So what do you do with so many autoimmune encephalitis and antibodies? Well, I would say that you have to follow a clinical approach. I mean, so if you suspect an autoimmune encephalitis and you send to Mayo Clinic all the panels on paraneoplastic and panels, whatever, that they do, which are mostly unnecessary for children, you, in addition of spending a lot of money and doing unnecessary tests, you are going to find also sometimes very false diagnosis and misleading the whole approach. So basically, you had to get familiar with the diseases, particularly with an NMDA receptor and MOGAD in pediatrics. Know a little bit about the GABA-A, but there is not too much to know. You have this MRI that I show to you. So check if the symptoms are subacute, most of the times, like develop in less than 3 months. If they are chronic, start thinking about something else. It can happen, but isn't common. And be aware of the syndromes. Become familiar with a MOGAD, I'm sure that you are, and with an NMDA receptor, and try to see if there is evidence in the CSF of inflammation or in the MRI, and exclude alternative disorders that in children, in pediatrics, you have many other inflammatory diseases, some of them even genetic diseases, mitochondrial diseases, and other types of inherited type of monogenic diseases that are associated with inflammation. And they are not autoimmune. There are inflammatory mechanisms, but they should be included in the exclusion of alternative disorders. And it can be very misleading, can have the MRI of inflammation in the brain, CSF with inflammation, and you have a monogenic autoinflammatory type of disease. So in adults, it's another story. You may do some sort of more wide investigation of antibodies, although I'm not very particularly fan of any panels. And in children, basically focusing these two, and if these two are negative, you may want then to start thinking about extreme rare diseases, but think about this. And always include CSF in your studies for this disease. Always CSF and serum, but always CSF is the way to prevent errors. So this is a study recently published by my group, actually. This is not longer in press. You can find this in neurology, neuroimmunology, neuroinflammation. Is open access, so you can access directly the paper. You don't have to be subscribed or to pay or to do anything. So what we did is that we wanted to see, okay, of all the patients that we are studying for suspected autoimmune encephalitis, of all these 2,750 children, extremely well studied for antibodies beyond the panels. We do tests with cultures of neurons, with tissue assays, with cell-based assays. So this is much more sophisticated with the test. Beyond that, how many have antibodies? Okay, so basically what we found of all suspected, not definite, suspected, we found that 577 had antibodies. And what was the distribution of the antibodies? Of this study, we excluded MOC. So this is why you see so few MOC antibodies, because the patients that clinically have MOGAD were excluded from the study, okay? But even after excluding the study, look at this. The two, basically, the predominant antibodies were an NMDA receptor and predominant and MOC, even after excluding the MOGAD. Okay, because in children, you can have MOC antibodies and you can have cortical encephalitis that doesn't have the flavor of demyelinating disease. And you can have some presentations more typical of an autoimmune encephalitis. But even after excluding that, so the two that you have to think about it is an NMDA and MOC. If you had included here the MOGAD, the two to include, the first one would be MOC by far, followed by NMDA, and then some unknown antibodies that against a no antigen, antibodies against a no antigens. But when you look at the other antibodies, it just basically 2% of all 2,750, and just basically 10% of all these 577 had other antibodies. Some of them not very well known. But for example, you don't see any LGI1 here. The reason is that we didn't find any on 2,750 patients. There are some patients, but in this study, we didn't find any. You don't see Casper2 antibodies. What you saw is GABA, you saw GAT, and pretty much not too many other, okay? And these were probably related to the tumor AGU, because these were patients with opsoclonus and teratoma. Opsoclonus and neuroblastoma. And neuroblastoma patients sometimes have antibodies against AGU, either regardless of if the patient has opsoclonus myoclonus or not. So this is, for you, should be very important, this slide, actually. So how do you treat these disorders? Well, most of them, as I mentioned before, the approach to treatment is basically following first line of treatment, as I mentioned, with NMDA receptor encephalitis. Second line with rituximab and or cyclophosphamide. There is basically no third line. Some people use tocilizumab, bortezomib, but there is very little evidence to use these drugs. If I had a child with an NMDA receptor encephalitis, very sick, that doesn't seem to respond, many times you have to wait a number of weeks, but doesn't seem to respond to rituximab, and I have to pick something, I would pick cyclophosphamide. Over all of them, I would never pick tocilizumab or bortezomib, because I know that cyclophosphamide combined with rituximab works better. That tocilizumab is shooting in the air in this disease. Unless there is a trial, we don't know. But this is common, it's customary nowadays. And we have this patient, let's do tocilizumab because it's much less toxic than cyclophosphamide. Well, yeah, probably yes, but is more efficacious or not? That's what you have to do. So this is very important to keep in mind. And then, of course, you have to treat symptomatically the patient. The patient has seizures, treat the seizures. The patient has a tumor, which in children, I didn't mention this, but basically in children, if they have a tumor, are going to be girls, usually above 12 years of age, and uncommonly to have a teratoma. Less than 12 years, all girls with an NMDA receptor encephalitis, they can have a teratoma, but very, very rare. It's very, very uncommon. So you can do an initial screening, but then you don't need to be exhaustive screenings every 3 months after this looking for a teratoma. You can repeat the screening several months later if you are still hesitant, but this is what the approach I would suggest. And then the clinical relapses, well, this can occur in all these diseases. And but if the patient received, for example, more intense treatment like rituximab as front line of treatment, the relapses are less frequent. So what about the pathogenesis? Well, let me go a little bit fast here, but in these diseases, remember that it's not that the antibodies reach the brain, but it's actually that the brain has the cells that make the antibodies. These are B cells, plasma cells, and these are autopsies of a patient with patients with NMDA receptor encephalitis. This is what mainly predominant infiltrates of B cells, plasma cells. There are some T cells, but less prominent. When you compare CSF with serum, the titers of in CSF are always higher than serum. There is an intrathecal synthesis of antibodies. There is microglial activation, but this is very non-specific. But then what you have in the brain of these patients is plasma cells. So the idea that the antibodies have to cross the blood-brain barrier, etc. Well, this in some of these diseases doesn't happen. You can have a blood-brain barrier which is with a lot, with very with the integrity very intact, and what you have is in the brain of the patients, you have the cells that produce the antibodies. You have B cells that arrive here and then expanded and mature, proliferate to plasma cells. What you see here is a brain of one of these patients, and what you see all these cells in brown are the plasma cells. Okay, so what do the antibodies cause? Well, the antibodies bind the receptor and they cause a dramatic decrease of receptors. So this is the autopsy of a control individual, and this is what you see is the hippocampus, and what you see in brown is the expression of NMDA receptors in the hippocampus of this control individual, and this is the expression of NMDA receptors in the patient. So it's not that the neurons are gone, the neurons are here, there is not too much atrophy, but the receptors are basically gone. So how this happens? Well, this is a common cartoon that explains the mechanisms of several of these autoimmune encephalitis. Well, let's focus in this one, which is the one in that you are more interested. And then NMDA receptor. Well, why the NMDA receptors are less expressed? Well, the antibodies bind to the receptors, as you shown here, and there is an internalization of receptors. So the synapse gets in some way depopulated of these receptors. There are receptors but many of them are internalized. And this is reversible. You remove the antibodies and then receptors again are reinserted in the synapse. So this is the main mechanism of action of these antibodies, with all what this represents for the neuronal transmission and then the symptoms of the patient, right? So we develop animal models. There are animal models now of a passive immunization and active immunization. The most interesting to me, I think that the first step is the passive immunization. So you want to see if the patient's antibodies are really not only internalize receptors and do all these things in cultures of neurons, but if you inject the antibodies to the ventricles, the way that was done here, you have pumps, mini pumps that are as called osmotic pumps that are filled with the CSF of the patients, connected to the ventricles through these catheters, and these pumps for 14 days infuse the antibodies to the ventricles. The antibodies diffuse to subventricular regions, but mainly to the hippocampus. And then you can see during these 14 days the behavior of the animals. So what you see here is that the animals that receive the antibodies develop this in this test, which is a test of memory, novel object location index. You see that the animals have a dramatic decrease of memory, and when the pumps stop, they are empty, they recover the memory. So these are control groups, but pay attention to this blue line, because this is not a control group. This is a group of animals that received the same antibodies, but were treated simultaneously with an allosteric modulator that is lipophilic, is a positive allosteric modulator of the NMDA receptor. And this positive allosteric modulator, the animals were receiving the antibodies same as this one, actually the same, from the same pool of antibodies. And what you see is that the animals, they don't develop long-term potentiation. These animals that receive the antibodies, flat memory formation, if you want, the paradigm of memory formation or potentiation. The green would be, this green would be the control animals, and this is also control group. But this blue line here is this one here. This blue line are the animals that receive the antibodies, but they receive at the same time this allosteric modulator. And what you can see is that these animals have long-term plasticity, which explains that they don't develop memory problems. So these animal models have become useful to test some treatment approaches beyond immune therapy, and that probably can accelerate, if used in the future, accelerate this long process of recovery of the patients. So what are the triggers of these diseases? Well, I'm going to concentrate for you, this is a complex slide. I'm going to concentrate in two main triggers, right? One of the triggers is one of the triggers in an NMDA receptor encephalitis is tumor. You have a teratoma, triggers an immune response. As I showed you before, antibodies, but mainly the B cells. Remember, the brain infiltrated to plasma cells. The B cells reach the brain and they expand to plasma cells here. And they make antibodies and they basically cause the symptoms, right? And this applies to an NMDA receptor encephalitis patients that have tumor. For patients that they don't have a tumor, an NMDA receptor encephalitis, we don't know exactly the mechanism. However, there is, and these only apply as very small proportion of patients with autoimmune encephalitis. There is a trigger that has been very well studied actually by people from my group, that is the autoimmune encephalitis that patients develop after herpes encephalitis. This is very important, particularly probably is one of the most important sections of the talk of today for you guys. So here you have a patient that develops herpes encephalitis. This is a little bit of hypothesis of what happens. The patients develop herpes encephalitis, and there is, as you know, there is a prominent destruction of neurons, a lot of inflammation. And what is speculative is that antigens are released and are presented to the deep cervical lymph nodes, which are the draining lymph nodes of the brain. And this triggers the immune response, and this triggers then autoimmune encephalitis, right? So is there evidence for this mechanism? Not yet, but everything points strongly in this direction. What there is very clear is the facts that this happens and that these patients develop autoimmune encephalitis, post-herpes encephalitis. These are two major studies actually that are close to more than 160, 170 patients prospectively followed from here. Again, be careful. This is not observational study of patients that develop the complication and there is a strong bias, etc. These are patients that from day one that they are diagnosed of herpes simplex encephalitis without knowing what these patients are going to happen to them, if they are going to develop complications or not, from day one are followed. And these patients are treated with acyclovir. On day 0, they start. Here they don't have any antibodies, any neuronal antibodies. The PCR is positive, of course, for herpes. You try it with acyclovir. Patients get better, recover more or less. You stop the acyclovir. In Spain, it's 3 weeks of acyclovir. And in Spain, by standard practice, the patients have another CSF analysis when they stop the acyclovir. In here, the PCR is negative, but then you find 40% of the patients that have antibodies against neuronal proteins. Many of them against the NMDA receptors, but some against the receptors and others, and some against unknown proteins. And of these 40%, approximately 25%, they develop a second wave. And this time, everything is negative, PCR negative, antibodies are present here, they were not present here, and this is no longer viral, but this is an autoimmune encephalitis post-herpes. So the numbers seem big, but this has been reproduced, and this is very solid. Be careful about 1 of every 4 patients or 5 patients that you see with herpes encephalitis is going to develop a clinical picture of complications post-herpes that is going to be autoimmune. And this usually happens within the first 3 months after the herpes encephalitis. And if the patient is younger than 4 years of age, almost all of them present with chorioathetosis. And this is what is present in all the books of pediatrics. For many ancient books of pediatrics, they already talk about chorioathetosis, post-herpes encephalitis, but the incidence and the mechanism was unknown. It was not even known that it was immune-mediated. Other patients present more an anti-NMDA receptor-like syndrome, which more or less overlap with this. And in adults, many have behavioral or psychiatric symptoms only. And we recently published in one of these papers the independent risk factors in developing this. Of course, the presence of antibodies at 3 weeks that were not present before. This is basically 1 out of 2 of these patients will develop symptoms. There was this HLA, the absence of HLA, that associated with the development of this complication. And then there is what's called the interferon signature that measures a number of genes that are activated by interferon. And in patients that they persist with symptoms that are viral related, viral reactivation, or symptoms, persisting symptoms, more viral related, this interferon signature is quite high. In patients that developed autoimmune encephalitis post-herpes, this interferon signature is not normal, but still high, but not very high. And in patients that they don't develop this, the signature is negative. So for an NMDA receptor encephalitis, the association with HLA is weak. It's very different from some other autoimmune encephalitis. Is relatively weak, and that's an observation that has been done by several groups. And I want to finish just to show you that these diseases have, the range of symptoms is very extensive. You have an NMDA receptor encephalitis that per se is a syndrome, distinct syndrome. You have limbic encephalitis that in children are very uncommon, but they can occur, and there are several autoimmunities causing limbic encephalitis, and then you have GABA receptor encephalitis and other. But we recently identified this disease that is anti-IGLON5 disease. IGLON5 is a protein that is expressed in the cell surface of neurons, and nobody has any idea of what this protein do. But it's certainly an important protein because in the cell surface. We have never seen a child with this disease, and there is no reported children with this disease. It has a very strong association with this HLA, and the patients, the core syndrome of the disease is a sleep disorder that affects REM and non-REM, and this is in a stage of sleep in that the patient should not be moving, and the patient is sleeping, has all these like pseudo-voluntary movements, like if it was drinking or eating. And this is a fascinating disease. The patients can present with several types of symptoms, movement disorders, cognitive disorder, neuromuscular junction disorder like fasciculations, sleep, bulbar syndrome, or even a PSP-like syndrome. But all of them, the presentation, any of these presentations usually leads towards the core syndrome that is a sleep disorder. And when these patients die, what is extraordinary, this is very uncommon. Uncommon, no, it has never been reported in any other autoimmune encephalitis. A percentage of these patients, when they die, this disease doesn't respond very well to the treatment. Everything is very different from the rest of autoimmune encephalitis. The presentation of symptoms is very chronic, sometimes even in years. And when the patients die, they have a novel type of deposits of tau that has never been reported before. And these tau deposits are in the hypothalamus and the dorsal tegmental region. This is more a curiosity for all of you. You're never going to be seeing this type of disease in children. I think never, based on the experience until now. But you may hear of this, and gives you an idea that autoimmunity have a very, far-reaching implications. In this particular disease, there is this intellectual question, right, of saying, well, is this an autoimmunity triggering neurodegeneration, or is neurodegeneration triggering autoimmunity? So what is in favor of this? Well, the specific antibodies, of course. What is in favor of autoimmune is specific strong HLA association. What is in favor of neurodegeneration? The chronic course. Most autoimmune encephalitis are subacute. The deposits of tau, that is not universal to all patients, but some patients. And absent pleocytosis, this is not longer true. There are some patients that when you study very early in the disease, they have pleocytosis. So all evidence goes in that in this rare disease, autoimmunity, by mechanisms that still we don't know, triggers neurodegeneration. And this is, I think, my final slide, or my before the credits. What you see here is that the antibodies of these IGLON5 antibodies, again, align with or alongside the fact that these patients don't recover. They cause this internalization of the IGLON protein, but this is irreversible. This is very different from an NMDA receptor in that this is reversible. And these associates with alterations of the cytoskeleton, which you see here in higher magnification. This should be very smooth like this in the control, very smooth neurofilaments. You see here these bundles, these ring-like terminations or early terminations. And so there is very active investigations now in this disease to find out how antibodies can lead eventually perhaps to tau deposits. Only apply to this disease. I'm not saying that Alzheimer or any other tauopathies are caused by antibodies, but this applies to this disease. So what I show you today is there is an antibody-mediated disorders of the synapse. There is a group of these disorders. It's a new category of diseases that has changed the diagnostic and treatment approach to neuropsychiatric diseases, but in all the fields, in adult neurology, pediatric neurology, even in psychiatry, because many of these patients initially present with psychosis. The antibodies have direct pathogenic role, alter the structure and the function of the receptors or other proteins, and leading to alterations of behavior in animal models. And that knowing these mechanisms perhaps provide in the future a better understanding not only of the disease, but also how to treat the patients. So this is my last slide. This is the group of people involved in this research in my group here in Barcelona, or colleagues in other institutions and the funding. And if you have some questions, I am free to take like five minutes question, because I have to leave then. 5-10 minutes question. Thank you.
Thank you very much. I guess we'll get started quickly to make the most use of our time. I think there is one question in the chat, and people feel free to put your questions in the chat or speak out once it's finished. One person did ask, in your experience, how much, I guess, autoimmune encephalitis have you experienced after COVID?
No, with COVID, we didn't find an increase of autoimmune. We published a paper about this. We didn't find an increase of autoimmune encephalitis, let's say NMDA receptor encephalitis or any other types of encephalitis in COVID, of this encephalitis. Okay. Now, if somebody is interested to know if there are post-COVID inflammatory disorders of the brain, but by other mechanisms, I'm not discussing that. But autoimmune encephalitis, there has been no increase in autoimmune encephalitis. The same that there has been no increase of multiple sclerosis caused by COVID, right? Yeah, you can find in Google, and you can find in PubMed, wherever you want. You can, at some point, when everybody, many people had COVID, many people had the vaccination for COVID, and at that time, you have an NMDA receptor encephalitis, you can implicate the COVID. But we examined around 10,000 samples during the time of COVID, and compare with, we examined several thousands of samples during COVID, and the similar thousands of samples pre-COVID. We didn't find a different distribution of or increased incidence.
Thank you. The person from Stroke who wanted to ask their question.
Yep. Can you guys hear me? Yep.
Yeah.
Thanks, Dr. Garcia. So I actually had a patient recently who had seemingly combined NMDA and MOGAD encephalitis, and he came into the neuro ICU from an outside hospital on 4 or 5 drips of sedatives because they just could not control his agitation. And so we were discussing, eventually we did start him on a ketamine drip, and I was curious, I raised the question at the time, and I guess there hasn't really been much research about it, but since you're affecting the NMDA receptor with the ketamine as well, since it's a blockade, I'm curious if there have been any sort of studies or anybody that's looked at how ketamine would affect people with NMDA encephalitis.
Yeah, no, that's a good question. Ketamine has been used also for patients that have been with teratoma, and the teratoma was removed, and sometimes part of the anesthetic management of the patient, ketamine was used. Initially, I had the same concern that you had. And of course, we don't suggest to use ketamine, but over the years we have heard of a number of, not too many, but a number of patients that for one reason or another, ketamine was used, and it didn't seem to affect very much the disease. The patients didn't become worse or didn't get better at all. You expect to get worse. There are even people that they use ketamine in very sort of wrong hypothesis that the ketamine was going to help patients with an NMDA receptor encephalitis without understanding very much the pathophysiology of disease or how the antibodies cause problems. And so, yeah, the world is big, and there are people that they do sometimes these decisions. But anyway, in one way or another, I didn't hear of differences. The patients didn't got worse or had severe complications, not at all. And I don't know how to explain that, but we didn't see that. Remember that the NMDA receptors are internalized, but not all of them. And so when you put cultures of neurons, I didn't show you the slide of this. This was published in Journal of Neuroscience a long time ago. So when you put cultures of neurons with antibodies, so you see a dramatic decrease of the number of receptors, but then there is a steady state of receptors that they are not more internalized, and they are not reversed to normal. As long as antibodies are there, the receptors are there, decreased, not disappear, decreased. And then you remove the antibodies and the receptors get again inserted to the synapse. So there is this balance and compensations that perhaps explain this absence of or minimal deterioration if the patients receive ketamine.
Thank you. I'll try to get to these questions in the order that they are put. One person asked, what is your experience with anti-dopamine receptor basal ganglia encephalitis? And is this a true antibody against the DR2 receptor?
Yeah, we did thousands of samples initially because in children, many of them have abnormal movements, and sometimes NMDA receptor antibodies are negative and so on. And we never identified dopamine receptors to the point that we stopped testing for these antibodies. So do these antibodies exist? Probably exist. They were reported by Russell Dale many years ago, and but how many patients and how many series have reported since then? Basically none. Basically, no. There have been a few isolated cases, but nothing. No, this is not like the NMDA receptors that every day you open PubMed and you find a new series and so on, or LGI1 or MOGAD. I mean, MOGAD is an explosion now, but no. So we don't have experience. I mean, I'm very familiar with the story of this, but we don't have experience with these antibodies.
I guess that relates to the next question in that, you know, for if you have a patient who has some level of suspicion for some type of autoimmune encephalitis, and these panels take 5 to 10 days to, you know, result, you know, would you go ahead and treat if you have strong enough suspicion? What is the risk associated with these therapies?
No, yes, I would go. This is the main reason we actually wrote a specific paper for this that was published in Lancet Neurology about the clinical approach to diagnosis of autoimmune encephalitis in 2016, Lancet Neurology. And then the question is that the people were too dependent on the panels and still are too dependent on the panels, and many times are misused. Many times the laboratories, they don't do a good job. Why not say it? And many times the physicians only send serum, and this is the perfect storm to make errors in the diagnosis. So you have to be first a clinician, and then you know and then order the antibodies to support. And if it doesn't fit your clinical suspicion, then this raises a flag, you know. It's like if any patient that comes to the ER and you start with an MRI without seeing clinically the patient, it's this is a little bit you know, caricaturesque, but sometimes it's like this, you know. I mean, without treating a patient, treating an autistic patient for autistic patient 2 years old. Because somebody identified voltage-gated potassium channel antibodies, treating the patient for 3 years, escalating to cyclophosphamide. This happened in the US. Just because had voltage-gated potassium channel antibodies, which basically didn't have them because this is a fluke. So this happened in the US. And that was one of the reasons that we decided to write this paper. And this is an extreme case, but this happened. And there are other cases similar. And this is the rapid. It has been very good to know all these diseases. Very exciting. We can help the patients. We can cure patients. We have improved the patients. But there has been also a side in that there has been not sometimes reasoning about this, in terms that you have to be first a clinician and then to find out if this fits with this. We publish in neurology. You can pull out from neurology a paper saying when a test overrides the clinical reasoning or something like that. It was published in neurology. It was a kid that came to us from the UK, diagnosed with an NMDA receptor encephalitis, only testing serum. Okay. It happened 2 things here. First of all, the physicians didn't do a clinical history, because the first thing that the mother came when she came through the door is show us the iPhone that was full of pictures of the kid falling asleep. Okay. So what this child had is narcolepsy, cataplexy. Narcolepsy in children, with the narcolepsy in children sometimes presents with also abnormal movement and the cataplexic episodes. So this kid came Cushingoid with steroids for I don't know how many months because of an NMDA receptor encephalitis. She was absolutely negative. She never had an NMDA receptor encephalitis. She had narcolepsy, cataplexy, everything, and or you know, the polysomnogram, the HLA, everything, the iPhone of the mother. So this is happening, and we have. I am in an age in my life that I can say it. If I was much younger, perhaps some people would say, you know, but I am in an age and I can say it. I have seen these errors, and these errors still persist, and people should keep balance of this, of be a good clinician. That's our job.
We definitely try in our training with our attendings to really use our clinical supervision, and a lot of us are familiar with the paper that you mentioned. I think Dr. Papamitsakas wanted to mention or ask a question.
Yeah, along the same lines. First of all, I very much appreciate your talk, and thank you to you and also to the pediatric neurology department who invited you. But the majority of the people who are here probably they are adult neurology physicians, and along the same lines that you mentioned, here we do a lot of these panels, either from the this company called Athena or to the Mayo Clinic, etc. And I've read your paper also, obviously, that the one that you mentioned, and some subsequent papers on the diagnostic approach and the focus on the clinical exam. But the reality is that when you suspect a patient like that, at least in the adult population, we really send the full panel. So that's something, I guess, that you and we do the CSF. I think in most of the cases, these people they get CSF testing, but you don't really recommend that particular approach, because I have to tell that in most of the places that I know, that's what they do. They just don't do a focused antibody, let's say an NMDA or
Yes, I've been in both sides. This is a very tricky, and this is very also delicate question to answer, right? I've been in both sides. I've been 25 years in the US, 24 years to be exact, and then in Europe, right? So what happens is that in the US, is very monopolized, the antibody testing. In Europe, the approach is different. Right? So, and I recently discussed this. The question you are mentioning is that physicians in centers, in general centers, they don't have way out. They order the panels or they don't order the panels. And sometimes even if you want to individualize the testing, is almost as expensive or more than to do the panel. And I don't know how to answer this, but this is something that, in my opinion, has to change. And it's a problem. I identify this as a problem.
Maybe ordering the most common ones, as you mentioned, the NMDA or more.
Well, in children, there is no question that in children, it's order a panel of anti-YO antibodies or PCA antibodies, 1-3 or 1-1. It's just ridiculous. It just doesn't make absolutely sense, because these are paraneoplastic, typical paraneoplastic antibodies with lung cancer, small cell lung cancer, with breast cancer. You can argue there is nothing, you can never say never, right? You can argue, oh, there is one patient that I saw among 10,000 patients, there is one. Okay, fine. You can argue that, but let's put common sense here. In children, basically, is if you suspect an encephalitis, there's going to be an NMDA receptor, there's going to be MOC. There's going to be then some aquaporin is another story, another scenario. And in adults, no. In adults, you have the repertoire is more ample, but in adults, basically, you have to think basically on NMDA receptor, also on LGI1, and then they come the white matter, the MOGADs, the aquaporin 4, and some of the other autoimmune encephalitis like the Casper or the GABA-B, GABA-B, GABA. I mean, these are others that can occur, but you have probably to check carefully these major syndromes associated with these antibodies. But I don't have an answer to. I don't know how to solve the problem from here. I don't know how to solve the problem and say stop doing the panels. I don't know, because they can prove me wrong. And I know that. I mean, sometimes there are patients with a typical presentation and you have this antibody, but most of the times, if you have a good knowledge of the most predominant symptoms and you order these antibodies, you are right, most of the times. This is an argument that in the American Academy of Neurology, it's always, I can take the role of the other vision of this and say, oh, we think that the panels are much better. Why? Because there are many antibodies that are continuously discover new ones. By the way, this is a false argument because many of these antibodies are not included in the panels, but despite that the panels are extensive, but they will say there are many antibodies and people are not aware of these antibodies. And, we think that is much better if we do this and we identify a disease for general neurology that are not so familiar with this. So how can I argue with that? And then they can say, well, for example, we have seen 3 patients, blah, 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 these ones. You cannot argue with that. But in some way, there is something that is wrong also in this argument. If you know an NMDA receptor, LGI1, Casper, and then basically the AMPA and GABA, the one that is important is IGLON5. Please look IGLON5 in the recent reports in neurology, because this is a disease that is missed. the central core of the disease is sleep disorder. Many of these patients are seen in centers that the sleep studies are done by pulmonologists, not by neurologists. And the presentation is chronic in about 60% of the patients. And they present like a chronic, sometimes neurodegenerative disease. So you have to think very carefully. You have to do a very good study with a partner, with a bed partner, which tells you how the patients behave during sleeping with REM sleep behavior disorder, abnormal movements, sometimes very abnormal behaviors during sleep, etc. But syndromically, NMDA receptor, LGI1, IGLUN, and then the AMPA, the other ones are basically suspect on the type of syndrome. For example, GABA-B, LGI1, and AMPA many times present with a limbic encephalitis. So if you have this limbic encephalitis, I would focus in these 3 antibodies, but I would not do these extensive panels, even though it's very difficult to solve that.
I mean, we can't always be perfect also, you know. I mean, we have this sense
Exactly.
here that we have to be 100% accurate all the time, but this is not practically possible, to be honest. You know? So sometimes time gives the diagnosis.
Yes, yes.
Anyway, thank you very much again. Thank you.
All right.
I guess I can send out your email if anybody has any extra questions, so as not to keep you from what you're doing. But thank you again very, very much. We obviously very much enjoyed this talk, and please have a good afternoon.
Thank you very much. Yes, if you have questions, please, now or in the future with patients, just please send me an email. Yeah, thank you for inviting me, and the questions have been very important and really on the target, the questions. So I recognize some of the questions and difficulties to provide answers. Thank you.
Okay, and take care.